Hello and welcome to this special Zoom meeting with the media and health professionals. I'm Donna Bush and I'll be facilitating this event this morning. First, we'd like to welcome the Interim Chief Medical Officer, Dr. Artelia Newton, the Chief Nursing Officer, Dr. Hazel Brown, Mr. Jonathan Smelly, the molecular biologist with the HSA's Forensic Lab, as well as other health officials are all joining us by Zoom this morning along with the media. Welcome to everyone. First, we'd like to go to the Interim Chief Medical Officer, Dr. Newton, who will explain the new format that's currently in place for COVID-19 reporting. Good morning, Dr. Newton.
Good morning, Donna. We're just going to share the screen so that people can see the this short presentation I've put together, to try to explain. So first of all, thank you very much for organizing this event today, which really gives us the opportunity to explain a bit more in details what we are trying to do on a weekly basis, what we will continue to do on a daily basis, and what those figures and things means, figures and graphs means, and how you can still try to improve, on what you're doing. So if we go to the next slide. Right, okay. So I would like to start by put there the formal definition of what a CTREP is, which is a form of status reporting that provides decision makers and readers a quick understanding of the current situation. It provides a clear, concise understanding of the situation, focusing on the meaning or context in addition to the facts. So what do we have in a CTREP? First of all, we have the facts, which are your numbers and your rates, so the tables and the figures. Then there is the context. So you can't really understand the facts if you don't understand the context. And, it's like, for example, the figures last week were pretty special because we were doing a mass testing exercise. So that's your context. Then the meaning, once you put together the facts and the context, then you can start asking the question, what does it mean? The CTREP is a live document which will evolve with time, and is right that it does that, because maybe bits of information which were very relevant at the beginning of a pandemic are less relevant now, and this is why you change it, or you add more things, or you take away things, exactly because you want it to be responsive to help you to understand what is going on. So, having said that, let's come to the first table. Now, we said that the CTREP is going to be made available to the media and to the public through the website every Wednesday. So you will forgive us if, as you can see, some of the figures there now are not yet available because we will have to put in the data which come in today. So the first one, this first table is really the crucial one. Because there you have the total number of cases to date since the beginning, since 2020. Then total Omicron to date. I will let Jonathan to explain what's going on there and how the lab is dealing with that. Then we have the total number of PCR tests which have been conducted over the week we are looking at, which is epidemiological week 3, which is the one between the 16th of January and the 22nd of January. So it goes Saturday to Saturday. The reason why we've chosen to go with epidemiological weights, because this is what internationally is the accepted form of presenting data. If we're going for something different, then we will be totally unable to compare ourselves with the rest of the world. So the total number of PCR tests conducted were 6,886. This is quite staggering. It's a huge amount, and we have taken away all the repeats. And again, Jonathan will explain what is the repeats. But this is reflecting the amount of screening that was carried out last week when we were trying to, because of the change in quarantine, so we had people who had been, who were eligible for release. And this is why we had to do all that testing. Now, the next one is very important because that is the number of new positive PCRs. And that's then with the sort of calculation you can do is really the basic number divided your population and then multiplied per 100,000 that gives you your incidence, how many new cases you getting in your community. The daily average positive, that's a number which is interesting, but it's a crude number, a raw number, which is not being manipulated in terms of further refinement. So with raw numbers, you have always to be very careful. They are important because they give you the dimensions. If somebody presents you only percentages, you have to be very suspicious because what is the reality? Is the percentage out of 10 or is the percentage out of 10 millions? You know, you need to have the basic there. But raw numbers can also be a bit misleading because they're not within a context. Then the next thing is the case rate. So that is the number of new PCRs or new cases multiplied your population, because the whole of our population is exposed, so we can use that denominator, multiplied then per 100,000. And the case rate, it is fairly high at the moment. Then is the next number put together the new cases, so the total number of new positive 2,739, plus the ones which were already there positive, but they are still positive. And this is why it's a bit like your prevalence. So is how many people in that week in the community were PCR positive. So these are the new plus the already the ones, the pre-existing one. And again, this is fairly high at the moment. The total number of cases monitored that week by public health is 6,016. And Dr. Brown will be able to talk to those figures a bit more into details. So moving on the inpatients, in the week, so as you know, we have inpatients both at HSA and the Health City. And basically we had 29 people who ended up in hospital or were in hospital that week. Of these, 26% only were vaccinated. So the majority were unvaccinated. And this is a crucial piece of information. The new admission over the week were 16. Now, as you can see, the next three numbers, we will be putting them in today for tomorrow. And the total number of people who have been in hospital since the beginning of the epidemic is now 174 up to the 22nd of January. We didn't have any deaths last week. And the number of deaths, therefore, is for AP week 3 remains at 15. So on the next slides, we are talking about the vaccination, and this is based on a population of 71,106. And as you can see, I think it's no point in me going through all the details there, but basically we have an incredibly high, very, very good first and second dose, but we're really still struggling with this booster, which is, there at around 28%. Is not where we want to be. We do need to move on. Maybe just to give you an idea, I was on Friday on the teleconference with all the CMOs from the UK overseas territories in the Caribbean, which is 6 of them. And none is very, very high on the booster. There is one which is on 36%, but otherwise they are all around the 30 or below 30. However, we keep repeating, as the Honourable Ministry of Tourism has quoted last week, we have the example of the UK where they were at around 30, and then in a couple of weeks, they managed to more than double that. So I think there is food for thoughts there. Now, this next figure or graph, what it tries to do is trying to put together the number of positive cases for the epidemiologic. No, this is still not being updated. So it's still referring now to AP week 2. And again, that will be updated by tomorrow. But what you can see there, that from the December, you have a low number of cases. And then as January comes in, after the holidays, we have this current spike of cases we are dealing with, this other wave of cases. Next one, again, has not been updated. The plan there, so this looks at the percentage of positives in the population in that week. That was the number I was referring to in the first table. Now, what we need to do with this is to make it against the number of tests that were carried out in that week, because that's a crucial piece of information, because if you increase your testing activity, you are expecting to see more positives. So if you look just at the raw numbers, you might be slightly misled and thinking, oh my God, they are going up, etc. If you don't look at how much test was done, then, then this is why I think we need to work on that graph and give you both figures. How much is the percentage of positives, and these are not just the new ones, these are also the ones who were positive that week, but against the background of how much testing was carried out. So it might take, more than a bit more time to get there, but that's our aim. Then this next one is, again, it tries to show you what went on from, that's the whole of the period, the whole of the pandemic. So it starts in March of 2000, and then it goes down to 2002. And you can see that the lines goes up and down, up and down. This is because has not been standardized or smoothed over as it will be in the next slide. And this is because there you are just using raw data. That's the effect you get when you have the raw data. Now, what is very interesting is obviously the Omicron coming in on the 7th of December, and then, you know, being quite a big spike, etc. But even more interesting is to see that also Delta appears to be climbing up again. Now, we'll come on that particular detail. We'll expand a bit more, but let's look at the next one. So the next one is part of the previous figures. There's more, you know, it's on a shorter time frame, because we want to concentrate more on the most recent peak that we have had. And the data have been smoothed over, the curve is smoothed over, because this is now an percentage, it is averaged over a week. Every week, the number of cases are averaged, and they are multiplied by 100,000. And again, it shows you, you know, it's a much smoother curve that you get when you, rather than when you use the raw data. So visually, it's a bit more easy to follow. But it shows the peak of the Delta in November last year, then going down, but now apparently going up again, and then Omicron coming in. Then that's a very good piece of information, because I think there was a lot of work which was done actually before I arrived with all the health providers and etc., and saying, okay, what is the maximum we can tolerate to make sure that we don't have to start reducing services, and that is your orange line there. And below you see the hospital inpatients, and you see how, thank goodness, we are far, you know, fairly far away from having problems with our services where they will have to start rethinking in terms of all the other things which are not COVID related. And then the last slide is a very important one, again, because it puts together the vaccination status of our inpatients. And as we said before at the beginning, in the first table, we do have that most of the inpatients are unvaccinated or partially vaccinated. The ones who are fully vaccinated with 2 doses, they tend to have a very large amount of comorbidity, so which makes them much more susceptible to you know, severe disease and even death. Again, on these slides, what we will aim to do is to dot around the deaths. So the 15 deaths we have had so far, they will be dotted around on the columns, and they will go on whether they were vaccinated or unvaccinated or partially vaccinated. So this is all in work in progress. I think I've finished with the presentation. I don't know, Donna, whether you want to start questions.
I believe, Dr. Newton, thank you very much for that. I believe we were going to go to Dr. Brown, just so she could give us an overview of how the public health staff actually comes up with these numbers, because I understand they're responsible for actually putting the numbers together and filtering them in. Dr. Brown, are you able to speak to that for us now?
Yes, I can. So, and just for the purpose of my conversation here, I've removed my mask. We're all masked in here.
Okay, thank you.
So just need to be clear. The data comes to us from a number of sources. So every agency that is doing PCR or lateral flow testing reports back into public health. And we combine that into what we call our case list, which is a single file that holds all of our current cases. You will notice that there's been a delay in changes in the numbers over time. So at this point in time, this morning, we can report on all of the information that came to us up to yesterday. But not all of the agencies would have reported on the same day. Some agencies may report once a week, some may report every few days, some report daily. In some instances, the particular agency may have delays within them. For instance, at the HSA, when we get to the large numbers that of cases of tests run. For example, last week, because of the change in regulations, we had a massive tests to try to release people who were on. Also, I'm not on camera. So we had a large number of tests, high demand last week, and that led to some delays. In addition to that, and Johnny will explain when he's talking to us about the lab processes, when we start to see large numbers of positives coming in, it's a requirement of the lab for accreditation to rerun certain batches, which again will slow our reporting down. So our numbers tend to be fluid for several days after the testing. As an example, yesterday, we were still getting results for the 20th because of the same situation that I described earlier, and Johnny can expand on that. Once we get all the data in, we have to then clean it. We have to go through, remove the duplicates, those who are retests. We use that data to release people who are currently in quarantine. And we use the retest data to also send people back for additional tests because we're getting a fair number of persons who remain positive at their scheduled retest. And then we have to retest. And then we can take out the new positives. So we get three kinds of results coming to us. We get the ones who are negative, who are already on our case list. Most of those persons release themselves when they get a negative result. So we don't worry about them too much because under the regulations, they can, once they have a negative result, they can return to their normal life. Then we get those whose CT values are so high that you know that they're no longer infectious, and we have to then release them. They may show positive on the result that they get from the lab, but they're not of public health concern because their CT values are very high. They've done a long isolation. They've been asymptomatic for many days, and we recognize that they're no longer a threat. And then we get those whose CT values remain low, who remain infectious. And we're having, particularly with Omicron, we're having people, what is appearing to be long isolation periods and people remaining infectious. So that's data that we will analyze later on as we go through the collection and cleaning of the data. And then we get our new positives coming through, which have to be treated then in a different way. Now, with the massive screening that's coming through, public health struggles, and I know you all have heard a lot of the complaints, and we hear them from you as well as from other people, the complaints about public health not reaching out to people who are positive. All of our communication from the Health Services Authority and from Public Health and even from the Ministry of Health say, if you get a positive, you remain isolated, and we give the instructions out of the regulations. If you are vaccinated, then you retest on day 8 now. If you are unvaccinated, you retest on day 11. And then that gives persons the opportunity to manage their isolation. And it relieves public health, because there is absolutely no way that we can call 6,000 people a week when we're working at this level. Back in December, we fell to under 200 cases, and we were really able to interact with all of the cases and support people in a much more effective way than we can this week when we're working with 6,000 cases.
Okay. Dr. Brown, thank you very much for that update. I see sitting next to you is Jonathan Smelly, the molecular biologist with the HSA's forensic lab. Do you have anything to add, Mr. Smelly?
I would say, I can take off the mask again. Sure. Hi. Yeah, so on Dr. Brown's point about the data and the fluidity of it, now the lab churns out PCR test results on a near 24-hour basis throughout the week. And because of so many different interpretation rules and criteria which are baked into our accredited process in the lab, we have to rerun some of those samples, right? And so as Dr. Brown said, we have a moving window of time that happens with the daily reporting, right? That looks into the past, because we are processing some samples again. And so we cannot necessarily pull through all of those reprocessed or those samples designated for reprocessing within the next day. And so those numbers need to be cleaned and interpreted and then pushed through to the next epidemiological week, right, in the SIDREP. So in terms of that, I think that they do an excellent job at public health of navigating the timeframes for that data and then being able to put it into these graphs that we see here. In terms of the variants, we had a focus, as I think is probably well understood by the public and the media, that our PCR test at HSA is able to differentiate between Omicron and other potential variants in the community. Now, we know from previous sequencing data that there are 2 different sublineages of Delta that were in circulation prior to the introduction of Omicron early December. That was the US circulating strain of Delta and the UK circulating strain of Delta. And so with genome sequencing, we were able to confirm that virtually all of the samples which we would designate as tentative Omicron or probable or possible Omicron, as patients may have seen on their report, we've been able to confirm by genome sequencing. So we've now shifted the focus away really from the Omicron and looked at the ones which we can't necessarily say one way or the other by PCR. And so that's led us to this insight into the graph that Dr. Newton was explaining earlier. So I suppose, which is what we see as the resurgence of Delta in this new wave, which is lagging in terms of case numbers behind Omicron, but still an increase nonetheless.
Okay, as we get ready to open the floor to members of the media for any questions that they may have, I do have a question before we get to the others. In relation to what Dr. Brown was talking about earlier, and not being able to respond to every positive, or to receive emails. Obviously, there have been people complaining about that, and I'm glad that you were able to explain how that process works, and that the impossibility of getting to so many people each week. I do know of a personal case myself where a young person was tested. Took them to get their PCR test done. There was no response as to whether they were positive or not, but they've been doing LFTs every day. And of course, the second marking on the LFT test is getting lighter and lighter and lighter. So we know that the person is almost at the end of their of having actually having COVID. So it's almost time now to go back to get that final PCR test to say whether they're negative or not. What happens if they don't get that PCR result via email saying that they are negative? What should be their next steps to stay within the law?
There are a couple of points there, Donna. First of all, we are receiving calls about results. We're receiving emails about results, because there are a couple of reasons why people aren't getting their results. Sometimes it's the lab that has to rerun these tests. Sometimes it's incorrect email addresses. Sometimes we have no email addresses. There are times when we have no contact details. We have many instances when we're calling the phone numbers that they're giving us, they're no longer in service, or we reached the wrong person. So there are a number of issues with us contacting persons. We do get the flu hotline emails coming in, and once we get those and we have a result, that result is attached to the response to that email. I get them myself personally, as do most of the other public health nurses, because we're fairly well known across the community and we do the same thing. Now, one of the things I'd like to comment on is the use of the lateral flow testing. And what you were describing there is actually not the preferred use of the lateral flow test, because lateral flow tests are designed to pick up early infection, but it cannot be used to monitor the progress of the illness. Long after the lateral flow test is negative, the person may remain infectious. And that's something that our population, I'm really struggling with getting people to understand. Once you get a positive lateral flow and you've done your PCR, you wait for that PCR result. It's really and truly a waste of lateral flow tests, because it doesn't, first of all, it doesn't change the outcome. And the PCR is the requirement for exit. Legally, once you're positive, once you're positive. So I personally am concerned, of course, for the environment as well, because as you know, these lateral flow kits are plastics, and they're, we don't have any way of recycling, and we're looking out at the dump and thinking about that as well. So I think if we could get the media's assistance with helping the public to understand the correct use of the lateral flow and put it into the context of conservation, as well as the value that it brings to the monitoring of cases and the outbreak, that would be very, very useful for us. I hope I answered your question.
Yeah, you did partly, but getting back to the question. So let's say the person has done their final PCR test and they still don't get an email, because this person has not received emails twice. Okay, and I know the case personally, so that's why I can tell you it wasn't because it was a wrong email.
Send it to me by email, Donna,
okay. and then
that's I'm happy to deal with those things.
Okay, thank you very much, Dr. Hazel, for that. Now we open the floor to members of the media for other questions. We're going to start actually with Wendy from CNS.
Caught me by surprise there, Donna. I thought you were going to Ralph first. Okay, let me start with the first question. Actually, it follows directly on from what you've just asked, Donna. I'd like to ask Dr. Hazel Brown. It's all well and good her saying, "Oh, I can catch up for this one person who sent in emails twice, and I'll deal with that, and we'll sort them out." But like Donna, and I'm sure every other person from the media on this call has been hearing the same things over and over again from millions of different people in the community. And so we're back to the same problem that you can't call everybody. Is there a case of like, we really do need to recruit more people still, and we need to address this problem? Because you're absolutely right, 6,000 people is a lot to call. But at the same time, if you've been in quarantine for 3 weeks and you're still waiting on an email, you can imagine how frustrating that is.
Well, Wendy, first of all, I'd like to say that we don't have to imagine how frustrating that is, because most of us have been there. So we acknowledge that. And from a healthcare perspective, we recognize not only the inconvenience, but the dangers of isolation and particularly the mental health consequences. So we're very, very keenly interested in it. Now, we are constantly recruiting. But if you think of it, when you see a surge in the population, we're going to have a surge in COVID positives even in our team. This morning, I've had 2 additional people go out positive. So yes, we're recruiting, and we have volunteers, and I'm sure some of you have heard my plea for volunteers. To the public to come in and volunteer with us and help us with making these calls, and also to reach out to apply if you're interested in doing even part-time work with public health to make these calls. We're very happy, but it's, our population is small, and the number of people who are unemployed who are able to volunteer is small, and the people who are really interested in doing this kind of work, they're few as well. So we are constantly recruiting. Like I said, I've got 2 new ones this morning. I had several new ones last week. Unfortunately, I get 2 new ones in, and 2 people have gone out with actual COVID themselves. Right. So, it's a balance, I think, that we're working on across the country, across the islands, just trying to keep our workforce in. And I mean, I'm suffering the same as other business owners. I had a conversation this morning with another business owner. He's, it's got large numbers of people out. And I mean, the Health Services Authority probably has over 100 people out this morning. Right.
Yeah, because 6,000 and some people being monitored is unsustainable as well. Do you, yes. What sort of situations are in place to keep people locked down? Because we're hearing horror stories all the time of bosses saying, "I don't care if you tested positive, you've got to come in, or otherwise I won't pay you." I'm hearing even of cases of health clinics where people are working in the health sector and they're working while positive. So we hear this, and obviously this is what's fueling the spread, obviously, of the virus. What can we do to try and curb this spread? Because although the officials said on Thursday it's their measures are working, it really doesn't appear so. Well, I don't know whether that is necessarily for Dr. Brown, but anybody who can answer that about curbing the spread.
I guess it would be me, because I'm dealing with it along with Dr. Williams in public health. Whenever we get a report of a breach, we attempt to attend to it. But you can imagine the workforce that's dealing with the breaches is also the workforce that's dealing with the swabbing and dealing with the contact tracing and all the other stuff. So we do attempt to reach out whenever we hear that there's a breach, but we won't know. We're hearing, and it's only anecdotal evidence that we have, that persons are doing, as you say, employers are saying to their staff that they're not to report their LFT, they're just to come back to work when they're LFT negative. That is a dangerous practice, because they probably are still positive. And now with the resurgence of Delta, we've seen more serious hospitalizations. It is of great concern, but it is the reality. We do believe that it's happening. We attempt to address it when we get a formal report, but for the most part, it's just stories that we're getting.
Yeah, I know it's a struggle, but it's a small community, so it sort of goes around. It might be the same story as well, being told a number of times, but it's definitely happening.
Yes, and when we get it, we actually act on it fairly quickly.
Also, can I ask about are there any issues at the lab with the qualities of the testing? I mean, have you had any problems with testing, which is also causing a delay? So I know you have to, by WHO standards, repeat tests, like basically to maintain the standards. But I just wondered whether maybe just the sheer workload is affecting the quality of the testing and the reliability and speed with which you can do it.
Well, there are three different sections there, right? Reliability, speed, and quality, and they're all quite distinct from one another. Right. Now, the WHO doesn't accredit the lab. The lab is accredited by A2LA, which is a accreditation board, certification board, that assesses labs for meeting certain criteria, right? So they've assessed us to meet ISO 17025 accreditation, and that's the accreditation we have for this process. Now, there's certain things that will impact on any lab, right? Being able to snap change into going from hundreds to thousands in a 48-hour period and maintain that. And now, obviously, that will impact on speed, that will impact on all sorts of things, because just as there are strains on the staff at public health, the same is true at the lab. One can imagine having to test thousands of samples in a 48-hour period is quite demanding, right? And so one of the things that you do is you put in place measures to reduce errors and to maintain a high quality of output whilst you're having to go through a surge in the amount of work you're doing, right? So measures which may not necessarily need to be put in place when you're dealing with hundreds of samples a day rather than thousands. And so those are the things that we've done to maintain that high quality output from the lab. And so that is part of the reason that Dr. Brown was speaking to with respect to certain timeframes being extended for patients getting their results, right? Now, also, for example, you mentioned a situation where, or anecdotally, where persons can be in 3 weeks quarantine waiting for their result. Now, there's a whole system of things that happen, right? Patients sort of perceive the swab going into the tube and then leaving their site, and then they kind of have an idea in their head about how long a process takes, right? But obviously it has to go to registration, get batched, and then it goes in a long line of thousands of tubes that then go to one lab and then go to the next, and then get reported out after interpretation to the patient. And so when you have a system like that, and you have measures and steps to ensure that quality is maintained at every point, you're going to have several hours in between.
And Wendy, if I might just interject here, maybe Jonathan, can you say what are the numbers of steps that you take when you carry out a PCR?
Oh, okay.
How many of them? We don't want to spend a lot of time, but just say how many of them, from extraction to results.
From the time when a sample reaches us in the lab till reporting out a patient's result, I would say there are probably 35 steps.
Wow.
And public health has a number of steps that have to be taken before it gets to the lab. So
and
so
of
it
course,
is.
a lot of those steps are repeated because we have to have 2 qualified persons review each set of results before they leave the lab.
Okay, thank you. I appreciate that. I've only got a couple more questions really relating to the hospital, so I can give others a chance. If there's time at the end, I'd like to add some more, but there's 2 critical ones that I want to ask about the hospital, or about inpatients. Number one is, given that we're looking at around 6,000 people being positive at the moment or thereabouts, how will this translate to hospital admissions, given that hospital admissions tend to come like a few weeks later after the peaks? So are there any concerns that we could reach that level where we start interfering with elective procedures, given the positive rate?
Okay, thank you.
Turn it to you.
Okay, thank you, Wendy, for these questions. Yes, we can access the proper modeling back from PHE. We can send them the data, and they can tell us a bit, because it's quite complex to do modeling. Before I send the information and get the modeling, I want to be sure that what we are dealing here is Delta. And this is why I'm waiting for Jonathan to finish the second and the third batch of samples which are going through the genome sequencing. Because one thing is if it's Delta, another thing is if, for example, we had the sublineage of the Omicron, which is the B2, which has now become predominant in one particular country, which is Denmark, where it was first isolated, but has been identified in 40 different countries. In the UK, they've had now already isolated 426 cases a couple of days ago, which is very much like Omicron, so less capable of a severe disease, but is, it's a new one. So
And very contagious.
it infects you, but that will be a different, because we are trying to talk about modeling. I need to know whether we have got that variant or it's all Delta. The other things that comes into the modeling again is the vaccination. And we're not in the same situation as we were before the vaccine came in. Because we are, our 2 doses is really, really very high. It's just the booster, we know that it needs to, to go a bit higher. So it's so complex doing the modeling. And as I say, once I get the information from Jonathan, I would be able to reach to the modeling team in PHE and say, just tell us, and then get a better idea.
Okay. Also, the other issue is, I think it's something that the public really need to know so they understand the dangers of this virus and not. Can we say obviously of the 15 people that have died, 2 had severe comorbidities and they were not vaccinated because they died before we actually had the vaccine. But since then, of the 13 people that died, we understand that the majority of them were not vaccinated. But can you also say how many of those people who died that were not vaccinated, but also didn't actually have a comorbidity either, and they actually died of COVID and not just as a result of COVID, obviously aggravating existing conditions, but were pretty healthy before they got the COVID and then died as a result? Do we have that number?
Okay, so we are doing quite a bit more analysis on that. From top of my head, what we got so far, I don't think any. Oh, Hector is telling me there might be one who was a healthy person with no comorbidity and end up on the losing their lives, but. Please just bear with mind a tiny bit longer, because I need to be absolutely sure what we are talking about and give you the correct information. You have also to think that, we have 2 sources, because one is the HSA, the other one is Health City, and we need to, we need to get to the same level of detailed information from them.
Okay, so that's the sort of information that will come later on.
Yes, yes.
And also the other thing that would follow on from that as well, which is, has anybody yet been seriously ill or died as a result of Omicron?
Exactly.
Do you know that one yet? You probably don't.
Don't yet, because
Okay.
this is another things that I want to be absolutely sure before I open my mouth. Yes.
Okay, Donna, I have some more questions about sort of reporting and numbers, but I'll let other people go first and see if there's any time at the end.
Sure. Thank you very much, Wendy. We're now going to go to Ralph from the Caymanian Times. Ralph? Ralph, are you there? Okay, I think what we'll do now is we'll move on to Ralph. You're there? Okay, please go ahead with your questions, Ralph.
Good morning. Can you hear me?
We can hear you and see you.
Yes,
Please go ahead.
Okay. Unfortunately, I wasn't able to join at the beginning, so I may be asking a question that was asked before. Just wanted an understanding regarding reporting of the numbers. What numbers we'll be getting on a daily basis and what numbers we'll not get on a daily basis.
Okay, so Ralph, if I may answer that, I think the ones we will get on a daily basis will be the new cases, so the new PCR positives, which I think is what people want to understand, on a daily basis, how many more people are testing positive. We will get the number of the inpatients with the number of admissions at the two sites, any deaths, and I think this is the basic that we want to release on a daily basis. The others, which are in the C-threads, are more, is wider information which has been worked on, and it gives you a much more precise idea of what is going on. But it's also the sort of numbers that you have to have a week to make them meaningful, to understand, because if I give you every day how many people have been vaccinated, 70 people, what does it tell you? It's not that it gives you a huge amount of information. So I think if we stick to the number of new cases, the number in hospitals, people who died, I don't know whether
The number of new cases is always going to be shifting, because remember, it takes
yes, with the caveat that Dr. Brown was mentioning before of all the complexity of this information coming in, and so they are a bit shifting and so on.
new cases.
I don't know whether Hazel, you would be able to give us on a daily basis how many people are being looked after in the community. I mean, they are.
It's always going to be a rough estimate, but we always have it. It's just that it changes hour to hour as we release.
Okay.
Is isolation in that number?
The isolation would be the number of cases.
Okay. Number of new cases, number of isolation cases.
All cases under care, or like all active cases, would be in isolation.
Yeah.
All right. Okay. And can you say how much of those are in your from the HSA staff?
I think you'd have to get that from the HSA.
We're just trying to determine the impact on the community, business
Yes,
community.
but that would be information that would have to come out of, because that is information, their own information.
Okay. Well, that's it for me for now. I'll let someone else ask some questions. Thank you, Donna.
Okay, thank you very much, Ralph. We're now going to go to Norma from the Compass. Norma, please go ahead with your questions.
Good morning, everybody. Thanks for hosting this. I think it's been really helpful. I've got quite a number of questions, so I'll try and keep them fairly short. I just want to double check on the chart that you showed, Dr. Newton, monitored by public health. I think the number on that was 6,018. Is that the actual number of active cases?
Yes, the 6,000 is the active case. Now, bear in mind that because last week we did all this huge exercise, this is why you have that very big figure there.
Mm.
Yeah, because lots of people were, had to leave. They were eligible
the
for
number of
quarantine.
PCR tests would have been affected by that. But
Yeah.
hopefully we would get and we have had a fairly large number of releases
Yeah.
out of that testing.
So the numbers then for the next week 4, should be lower.
Gotcha. Okay. And is there any, because there's obviously PCR tests being taken when someone goes into isolation and then again at exit, does the timing of the week of figures that we're looking at completely negate the possibility of a PCR test which is returning positive being counted twice on the same person?
We separate the new PCRs from the we did, and this is why it takes so much work, right? Because we're trying desperately to give you as precise information as possible. So we deduplicate, and I'm using the pluralis majestatis, is these people working on it. That's what they do night and day. They deduplicate from somebody who is the first time comes PCR positive. Those are the new PCRs. And then when I said, we will put together, so that will give you the incidence. But then when we put together those ones plus the others who were already there, but because they are receiving, the clearance tests, so they've done another PCR, that's together will tell you in that week how many people in total were PCR positives, divided your population, multiplied by 100,000, and that's your prevalence.
Okay, gotcha. Could I also ask, reinfection rates, are we seeing any of those locally? People perhaps who'd had Delta before who are now getting Omicron?
Oh, yeah. That's the problem.
We're seeing Alpha, Delta, and Omicron.
Yeah.
Oh. So, how prevalent is that? Do you have any kind of breakdown of the numbers of reinfection cases?
No, I haven't been able to do that. We have to, so we have an active case list that we work on, and then we add that into our mass case list and deduplicate. Of course, in the deduplication process, we have to be alert to these reinfections, which we started to see back in October, November. So, it's going to take us some time to get that combined done and the second deduplication process. That will take us some time.
And if I may add here, now, this is, again, is very crucial piece of information, because we have to link that to the vaccination status of these people getting reinfected.
Yeah.
Because if are they, non-vaccinated, well, you would expect that. But if they are fully vaccinated but not boosted, that will give us yet more evidence that we need the people to get the booster. But it's quite, honestly, it's quite not difficult work, but it's, it's complex. And this is why we can't rush with these sort of things, or being able to, the current technology, the fact that the different systems do not talk to each other, and so every time a spreadsheet has to be deduplicated and put in the master database, etc. That's what it takes a lot of time. And this is why this more sophisticated calculation, which will give you a much better idea of where the problem is, it takes, unfortunately, a bit of time to reach.
Okay. Do you have any timeline on when that information might be available?
No. Actually, we're hoping to get some IT staff on. Actually, one will be starting with us this week. Someone, very, very experienced data manager who will assist with this. And I know there is an epidemiologist coming at some point, a consultant coming into the Ministry of Health that will also assist So what we're trying to do right now is to get the data clean, that we can have it ready for epidemiological assessments and analysis.
Okay, I understand. Thank you.
You can understand that it's the same people who are doing the actual work of managing cases and conducting vaccination clinics and testing are the same people who are assisting with the data management. So you can understand that it's going to take us some time.
Sure. It sounds like a lot of moving parts to organize there. Let me just see what my next question was. I know we've spoken about it, but the Delta cases going up. I'm not quite sure I understood. Are you saying that there's a new version or new variant of Delta that's being counted as those numbers?
No.
Yeah, I'm sorry. I didn't quite get that.
So, what we're seeing is an increase in the number of cases of Delta, but it's the same circulating lineage that was present before. And the genetic characteristics of it are also the same. So there have been no changes in the underlying genetics of this variant that have been in circulation. And it's also the same one as previously identified. So it's the sublineage called AY5, which is kind of more related to the circulating lineage of Delta in the United Kingdom.
Yeah.
Okay. But Delta, I mean, in the US, I think by the first week in January, 95% of all cases were Omicron rather than Delta. I mean, is there anything specific to Cayman that's making us see a resurgence or a continuation at least of Delta cases here? Is there anything unique to us that explains that?
There are all sorts of temporal dynamics when it comes to transmission of the virus. And really, a lot of countries are seeing a dual wave, right? And you have these super transmission localities amongst unvaccinated persons in other countries. I can't speak to the characteristics of that epidemiologically, but the reassuring thing is that it's no different to what we've experienced.
If you think of a case, their social behaviors and personalities can have one single case can be responsible for that spike, depending on the behaviors of the individual. So if we had an individual who, for instance, one of those persons that we were talking about just now, who did an LFT, got a positive, may have stayed home a couple of days until they got a negative LFT and went back out on the road and it was a Delta, we could, that entire surge could be attributed to one case that behaved irresponsibly.
I see, okay.
We need to keep that in mind when we're seeing these things. It's not that we've had multiple incursions. It could just have been the tail of the previous one, and somebody behaved irresponsibly, went to a large event, and multiple people were infected.
And the other thing is that you have to take into consideration the fact that the vaccine protection went down after a number of months. We know that. And this is why the idea of the booster came in, which at the beginning was targeting only the at-risk groups, the very elderly, the more frail, etc. And then how the evidence started accumulating internationally, it was that, no, that's everybody needs a booster now. So it could be also somebody who might behave in the way that Dr. Brown was mentioning, but thinking, oh, hang on, I am doubly vaccinated, so I'm not a big danger here. But unfortunately, we are in that situation where we need everybody to get that third dose to make sure that we can try to control the spread of infection. As I say, I don't want to say a definite word until we get the information from the lab that what we are seeing in this spike is in fact a resurgence of Delta. So we want to make absolutely sure, but we certainly we'll use that information then to booster our boost campaign.
Gotcha. On the subject of boosters, it's been several months now since the booster was introduced to Cayman. And I'm assuming that it works on the same premises. The longer you're vaccinated, its effectiveness wears out after a little while. Is there any plan, Dr. Newton, to advise the introduction of a fourth jab? I know some countries currently actually require a fourth jab, maybe not fourth jab, but a certain amount of time from when you were when you received the third jab. Is there?
No, there are no plans for right now. I mean, in some countries in the world, they are start looking at fourth dose, but it looks like, again, it will be really for the very, very vulnerable ones. However, nobody has proceeded so far with that because there isn't enough evidence. Because what you have to do now, okay, you have given the booster. Now you have to wait a number of months to see whether the immunity will wane even after the booster, and whether also you get new variants coming up which might not respond to the vaccine. So this is why it's far too early to mention anything like that. We have also to bear in mind that it might be that in the future we will deal with COVID a bit like we deal with influenza every year. That you get one vaccination a year because the virus has mutated so much that your vaccine is not effective. But it is far too early. Now, the other things that Dr. Brown was trying to prompt me to say is also that at the moment, because we have got still a part of our population which is not vaccinated at all, and these are the children between the age of 5 and the age of 11. Until we can tackle that, that's another bit of reservoirs where the virus can circulate. So we are really waiting very eagerly to hear about the business of, the go ahead that we can vaccinate also everybody offer the vaccine to everybody between the age of 5 and 11, alongside the booster for the rest of the population. And that will bring then how defenses against the circulation of the virus on a much more solid base. At the moment, I think it's the next Saturday, this Saturday, the 29th.
By appointment only.
By appointment only. The children between the age of 5 and 11 who are in the at-risk categories, they can be vaccinated. But let Dr. Brown to explain a bit more detail.
So we are going to we're going to run a special clinic for the at-risk children. It hasn't gone out. You haven't received a press release, and that press release have all the details of how to access it. It's going to be by appointment only. It's going to be run by the public health nurses because they are the persons who have the particular experience and skill around vaccinating children. God, we're going to need.
Sorry, one of my colleagues just sneezed incredibly loudly.
We're going to let him do an LFT. We're going to be advertising that and asking people to reach out and make their appointments because we're going to have a limited number of slots. We're being very generous. We're going to have a number of people working the clinic, but we still have to keep it by appointment to reduce the chance of any transmission coming out of a clinic setting. So you will be getting more information on that, hopefully by the end of today, but if not, definitely by tomorrow, because we have to give people time to make their appointments and come in.
Super. Thanks, Dr. Brown. On that subject, Is resources the only reason why children generally 5 to 11 are not being offered the vaccine, and currently it's only available to at-risk kids?
No, it's nothing to do with the resources. So there are two issues there.
Vaccine is a resource.
One is that the vaccine which is available at the moment is the adult vials. Now, with the adult vials, you have to have very experienced people giving the vaccination, because this is really a tiny dose. It's a fraction of what you give to the adults. The proper preparations, the children's vials are not going to be available. Well, they should arrive in the UK by the end of this month. And then, you know, there is a quota which has already been allocated to the UCOT, including Cayman. But as you can imagine, if it doesn't arrive there, then it can't arrive here. The other is the advice which is given by the Joint Vaccination and Immunization Committee in the UK, which advises the government there on who to vaccinate, which groups, etc. So at the moment, they have taken the stand that only children in the at-risk group should be vaccinated. But they are due to meet again shortly, hopefully this week, because they said they wanted to see more evidence, and then they will give the advice on, they will deliberate on whether to open it to all the 5 to 11, which is already what is happening in a number of other countries, to be honest with you. So we're just waiting for that.
Okay, thank you for that. Just one last question, and I'll hand over to anybody else who has more. Is there any indication at the moment whether the Novavax vaccine might be available in Cayman? I believe it got the go-ahead in the States by the CDC last week or the week before.
Well, that will depend on whether the UK government will buy it or not. But at the moment, what we get here is the Pfizer, which comes free to us. And that's, you know, I think we need to bear this one in mind. And we have, you know, enough. We had it very, very early on. And the other thing is, and we also get the AstraZeneca for people who have specific allergy to the Pfizer.
Okay, so on that we just need for an okay from the UK if they want to.
If they decide to buy it, then you know it goes. But as I said, you know, if you look around the world, just forget for a moment about Cayman. If you look around the world, Cayman was very, very lucky because they start getting the first batches of vaccine in January 2021. A lot of countries, they didn't see any vaccine arriving for many, many, many months. It was much later, even in the Caribbean.
Mm-hmm. Super. Thank you all for all your answers. I'll pass over to another reporter now. Thanks.
Okay, thank you very much, Norma. We're now going to end with Kevin Watler from CMR. Kevin?
Thank you, Dawn, and thank you, everyone. Got a quick question about breakthrough cases and how they're counted. Are breakthrough cases included in the total cases to date count that you showed in your first graph?
Breakthrough cases would be those cases who are already vaccinated.
That is correct.
I think we report our vaccinated and unvaccinated numbers.
In the hospital.
Or in admissions. Yeah, we do report it with admissions. We collected from all cases, but as I was explaining earlier, we don't have the resources to always call every case. So every time we make a call, that's one of the pieces of information that we collect. But because of the surge and our difficulty reaching every person, we don't have complete data on vaccination status of all cases.
Of the new ones and so on. So again, this is something that we might aspire to get there, but it does take a lot of effort and quite a bit of time to put that type of information together. And we certainly can't do it now with 6,000 in the community, you know.
Good. Next question is, have we identified any double variant infections, as in they're both Omicron and Delta positive at the same time?
No.
No. Jonathan?
No.
No. Confirmation. Confirmation. We get people who have got infected with one things and then they get another one, but not at the same time.
The closest together was probably about 3 months. Someone who'd had it in October, November, who are now positive for Omicron, but
Yeah, my nephew is actually one of them because he had it in November and now he just tested positive a couple days ago.
yeah.
So, sequencing, is sequencing taking place on all PCR tests, or is it you guys just taking a sample of it?
So the framework with which we use to determine what to sequence this on is still a moving target. Now, obviously, with thousands of positives, there are challenges with getting through that number. We aspired to September to sequence every positive case. And I think we will get around to it eventually, but we're focusing really on high value positive samples. So ones where we are now, because I said earlier, we're now shifting focus away from Omicron and looking at what other variants may be in circulation. And so those are the ones that we're prioritizing for sequencing. We prioritize sequencing for cases where persons are particularly ill or hospitalized. And that's really our main focus for now.
All right, that concludes my questions, but I do have a recommendation before I leave for Dr. Brown. You were saying that you guys are looking for volunteers, perhaps. I don't know if you guys have approached your CERT teams and see if they would like to utilize them to be able to assist. I think that's one of the reasons they're around.
Who did you say, Kevin? I'm sorry, I missed that.
CERT.
Oh, you mean the community emergency response teams?
Correct. Yeah, that would be through hazard management.
No, I've just really set it out generally to the in press briefings and that sort of thing. Asking, we've reached out in the past to hazard management for assistance, and they've helped us on occasion with like food deliveries and stuff. And in fact, they've taken that over, the social support. But no, we haven't really reached out to them.
Might be a good idea, a good suggestion, Kevin.
No problem. Just throwing it out there. I know that's what we utilize because I'm based in Florida, and so that's what we have utilized when we needed some extra help with hands on deck. Because not any person in the community obviously could do some of this stuff, especially the confidential material that they're going to be handling. But that's a little different level, and they have some level of training to assist with that. So I'm just passing that on. But that
a good idea. Yep.
Okay, if that's it for questions, unfortunately, we do have to wrap up the Zoom meeting with our healthcare professionals. Any final words from participants from the healthcare panel?
Donna, first of all, I would like really to thank you, to thank everybody. I was hoping that we could be as transparent as possible. We've told you all what we have, all the difficulties and challenges that we have. And I really appreciate all the questions, which were very, very pertinent and very relevant. And I also hope that we have managed to provide you with the most honest and precise answer we could master. I don't know whether Dr. Brown and Jonathan want to add anything.
No, I'm just glad that we've had this opportunity to have a conversation. Sometimes we feel a bit slammed by the media as we're working very, very hard. And I'm just grateful that you've taken the time out to listen today to hear some of our realities. And I hope that we can work together to try to get the country through this very, very difficult time.
Okay, thank you very much to all of you, and of course, members of the media who may have further questions to ask. I'm sure that you'd be more than happy to answer their questions or for them to reach out to you, to each of you with those questions. I'd like to thank everyone for joining us on this special Zoom meeting with our healthcare professionals and of course the media, and for them sharing all of the information as it relates to COVID-19 numbers and much more. I'm wishing everyone out there a great day.